Thank you for joining us and for your interest in the documentation guidelines for coding, what auditors look for. The American Osteopathic Association is in a relationship with the Coding Network. This relationship allows us to reach out to the Coding Network to help our members when they're involved in audits, when they want more information on coding, documentation, and the likes. That being said, that is how we've come up with this, providing this presentation. We originally presented a live presentation on January 9th of 2019. Due to some technical difficulties, we've decided to re-record that presentation and do this with just the speaker. Our presenter today is Susan Carbone. She can tell you a little bit more about herself, but as you can see on this slide, she is very well prepared and an expert on the topic. So with that, I will turn it over to Susan.
Thank you, and welcome everyone to Documentation Guidelines for Coding. What auditors look for will be the focus of this. And again, I'm Susan Carbone with the Coding Network, and I do a lot of auditing, and I also provide physician education. So let's start with the course agenda. I will go over the components of E&M services, and then talk a little bit about E&M categories, such as new and established patients, but also documentation requirements for procedures such as OMTs, trigger points, acupuncture, and documentation requirements for those same-day E&M services with the procedure. I'll go over a little bit about ICD-10, diagnosis coding, and clone notes, and some 2019 updates. But let's start out with references. I like to reference the Medicare contractor, which is National Government Services, and there's a link there, a lot of good coding information on that website. They also provide what they call a local coverage determination, and this one's specific to OMT, so it's a very good document to review as to what their guidelines are. Don't forget your ICD-10 official guidelines for 2019, and there's a link to that. And also a reference to the American Osteopathic Association. They have a guide to coding and documentation, including the OMTs. So let's start out talking about the E&M services. And there's actually 7 components for E&M. Now, most of you select your E&M service based on the first 3. You look at the history, the exam, and the medical decision-making, but just keep in mind that there are several other components. Sometimes based on counseling and coordination of care for that visit, time comes into play, and we'll talk about that separately. And then number 6, the nature of the presenting problem is just an additional consideration that we will look at. But let's start out talking about the first 3 key components, what you typically use to determine your level of service. Taking into consideration what they call the nature of the presenting problem. And there's 5 of them. What this really has to do with is the nature of the presenting problem the patient comes in with should correlate to the level of service chosen and the complexity. Now, the first 2, minimal and self-limited or minor problems, typically these don't come to a specialist office. So most of the problems that you're dealing with are either going to be low severity, moderate, or high. And again, making sure that the level of service you choose correlates to that. For example, you wouldn't expect a high level of service if the nature of the presenting problem was something of low severity, a very acute but uncomplicated problem, for example. But let's take a look at this one-page new patient template. Okay, so this has all your new patient codes on it, from a level 1 all the way up to a level 5. And what I want to point out first is that there's these typical times associated with these codes. Don't worry about these times when you're selecting your level of service based on those 3 components of history, exam, and medical decision making. These are just typical times. These were averaged out 20 years ago. They may or may not still be accurate, probably not. For example, if you had a 99204 because you met all the criteria, but then you looked at the time and it said it should take you 45 minutes, but you were able to do that in 30 minutes, that's okay. You're not penalized for being more efficient. So let's take a look at the criteria of new patient visits, keeping in mind you have to meet the criteria for all three key components of the history, exam, and medical decision making. So let's just take a look at 99204. CC is a chief complaint. That's always required on any record. Why is the patient being seen? It requires, for the history component, HPI is history present illness. At least 4 elements would be documented. ROS is review of systems, at least 10 or more. And PFSH is the past family and social history. All 3 are required for a 99204. So this portion is the history. The second component, key component, is the exam, which would need to be comprehensive. And then medical decision making would be moderate. So those are the 3. Comparing that to a 99203, for example, which doesn't require quite as much, still need those 4 elements of HPI for even a 99203. But for a review of systems, you only need 2 up till 9. So you could have as few as 2. And then for the past family and social, only requires 1 of those. The exam would be detailed, and medical decision making is low, so that's that low severity. When we look at the established patient codes, anything from a level 1 all the way up to a level 5, first of all, keep in mind that you as a physician, a provider, an NP, a PA would not be using 99211. That's not meant for a physician, but it could be anything from a level 2 to a level 5. Again, they have the typical times associated with them. Don't worry about that unless you're selecting your code based on time, and we'll talk about that separately. You only need to meet the requirements for 2 out of the 3 key components. So let's just take a look at a level 4. Well, we know we need the chief complaint, but it's got the history elements here. So the HPI is 4, review of systems 2 to 9, past family and social at least 1. Second component is exam, needs to be detailed. Third component, medical decision making, moderate. If you met medical decision making as moderate and you met exam detailed, but you didn't quite meet all the requirements for the history, that's okay because we can just count these 2 components of exam and medical decision making. Don't have to count all 3, can drop the lowest scoring one, so to speak. I do recommend that you always use medical decision making for these follow-up visits as one of your key components. And I only say that because CMS is kind of heading in that direction. They haven't exactly stated that, but what they have stated is that, first of all, they're looking at these documentation requirements, realizing they're too complex. They don't quite follow well with the EMRs, and there's too much documentation requirements. One of the proposals that is coming up is that they may just start putting more emphasis on the medical decision-making piece. So I just wanted to point that out. Just a quick definition on new versus established patient visits. Remember, your new patient visits, you or anyone in your group, specialty group, has not seen that patient face-to-face within the past 3 years. Now, if you do happen to have a new patient coming into the office and ahead of time you have them have done some diagnostic testing, they can still be a new patient when you see them as long as you haven't yet had that face-to-face service. And then, of course, the established patients are the ones that you or anyone in your specialty group have seen in the past 3 years. So let's just go over these key components of history. Again, making sure you have a chief complaint or reason for visit. Your HPI elements, we'll go over that, the review of systems, and the past family and social history elements. Make sure that you have a chief complaint or reason for visit documented. This establishes the medical necessity for the service. And when we talk about the E&M with a procedure, for example, with the OMTs, you want to make sure it's very clear in the beginning of the note the intent of that visit. So let's take a look at the history. Remember, to qualify for a given type of history, all three criteria of HPI, review of systems, and past family and social must be met or exceeded. So what does that mean exactly? Let's take the comprehensive exam. You need that for a level 4 or 5 new patient visit. You've got to meet all the criteria here of 4 HPI, 10 review of systems, and the past family and social history. If you fall short on any one of them, for example, maybe you only documented 9 review of systems instead of 10, you're going to default to detailed. For a new patient visit, that's going to cause the level to drop to a 99203. So quickly, let's take a look at the elements of history of present illness. There's 8 of them, and I'm going to go over the definitions briefly for you. Location, of course, is where it's located. The quality, any characteristics that you can describe. Is the pain sharp, dull, radiating? For severity, it could be the pain scale, or it could be simply stated the patient is feeling better or they're not. Duration is how long the symptoms have occurred. The timing is the regularity of the occurrence. It could be stated as during the night, it's frequent, it comes and goes. Context would be how the complaint occurred, so any circumstances, hurt back in a motorcycle accident as an example. Any modifying factors, over-the-counter meds are helping or they're not helping, and then any associated signs and symptoms. But just keep in mind, in 2 simple sentences here, you can easily capture your 4 HPI elements. And remember, you need those for your new patient visits. Level 3, level 4, or level 5. So don't fall short on that. I didn't see that as an issue in your notes, but it's just a good reminder. Now, as an alternative to documenting these HPI elements, there's something called the status of 3 chronic conditions. And this could come into play with the follow-up visits, probably more so, where instead of worrying about the HPI elements, you could just document the status of the chronic conditions. And if you document 3, for example, that correlates with the 4 HPI. You don't need to do both. You can just do one or the other. But what would the documentation look like? This would be in your history section, and this would be probably information coming from the patient. This is not your assessment and plan, but this is the history portion, and the patient may be saying their status of their problems. Just document it. The OA of the left knee is not improving. I'm still struggling with low back pain, but my left shoulder is a little bit better with meds. Review of systems, there's 14. This is the questions and answers with the patient. Just keep in mind for your higher level new patient visits, you need 10 or more review of systems. So for new patient visits, level 4 and 5, and also for consults, levels 4 and 5, you need a complete review of systems. That means at least 10 are documented. Now, there is another way that you can document the review of systems by documenting all the pertinent positives and negatives, and then you could state the remaining systems, all other systems have been reviewed and are negative instead of individually documenting them all. Now, from your notes, at least the ones that I looked at, it looks as though you are documenting them individually, which is fine. And actually, I think it's probably a better idea to do it that way. But I'm just pointing out that there are what they call completion statements, where once you have documented the pertinent ones, you could state all other systems have been reviewed and are negative. And there's a couple of other statements here that are acceptable. What you don't want to do is just make a blanket statement about the review of systems, that they're all just negative or unremarkable or non-contributory. If you're unable to obtain any of the information in the history, and if you state why, you can still get credit for that history portion. Past family and social history, well, these are examples of past history, so you only need one item. Family history, a review of medical events in the patient's family, any diseases, anything that's pertinent. One of the things I want to point out, some of the insurance contractors seem to take issue with the statement, family history non-contributory. And I believe it has to do with the EMRs, and they feel that maybe that's some sort of default statement, and they're not sure that their family history was actually reviewed. So what we recommend, if it actually is non-contributory, just state that you did review the family history and found it to be non-contributory. And the social history, again, any one of these items would qualify. Let's go on to the exam portion. This is key component number 2. And there's 4 types of exams, anything from problem-focused, which would just be limited to one body area or organ system. Expanded problem-focused is a limited exam of maybe 2 or more, but it's limited, not very detailed. The detailed exam is more extended exam of the body areas or organ systems. And then the comprehensive, there's a general multi-system exam. That comprehensive would require at least 8 of the organ systems documented. There's also, as an alternative, a single organ system for the guidelines for some of the specialties. For example, there is one for musculoskeletal, and I'll go over that with you. But the 95 guidelines, this is the multi-system, and I did see that in a lot of your notes. This is what you're using. That's fine if it's working well for you. I just want to point out the 95 guidelines that use the multi-system. They've differentiated, for whatever reason, body areas from organ systems. Okay, so they've got these body areas listed. For example, the head, the neck, chest, abdomen, just the back of each extremity. And then they've got organ systems. Where does it make a difference? It makes a difference for the comprehensive exam only. That comprehensive exam is what you need for the higher level visits. You've got to document 8 organ systems. Keep in mind, constitutional is one of the organ systems. That could be 3 vital signs, or it could be simply stating the patient is in no apparent distress, or just describing the patient status. Keep in mind, eyes and ENT are separate. But if you documented 7 organ systems and you wanted a comprehensive exam, and one of them was a body area such as the neck, you would not get credit for the comprehensive exam. But for the neck, and a lot of times the neck is examined, if you mention the lymph system when you're examining the neck, that will get you to an organ system. So the 1995 exam, where auditors have problems, is what's the difference between an expanded problem-focused exam and a detailed? Because that certainly could make the difference between the level of service if you're counting the exam portion, particularly in the follow-up visits. Well, the definitions are pretty similar, with the detailed exam just discussing 2 body areas or organ systems in greater depth. So they each require at least 2 to 7. So I'm going to go into a little bit more information on what a detailed exam would look like. And then keep in mind your comprehensive, you need 8 or more of the organ systems documented. So a detailed exam, definition, 2 to 7 body areas or organ systems. And this is from National Government Services, which is the Medicare contractor. They're looking for expanded documentation of the areas or systems examined, requires more than a checklist. Need to have normal and abnormal findings expanded upon. So for instance, musculoskeletal, several items are in detail here. And I do think that your exams are not a problem from what I've seen. They're definitely detailed. You have at least 2 systems which has detail. Several items in each system are separately documented. And then, of course, the comprehensive exam would look something like this, where you have the 8 organ systems from constitutional, eyes, cardio, abdomen or GI. There's 8 here. Now, there is a 1997 exam that came out that is very specialty specific, and as one of the examples is the musculoskeletal system. But their requirements are a little bit more stringent, they're a little bit more detailed. So if you look at, for example, a detailed exam would require 12 elements identified by a bullet, and we'll take a look at an example of that. The comprehensive is all elements identified by these bulleted items. And although this didn't come out well on the slide, I can send a copy of this if anyone is doing the 1997 exam. But as you can see, these are the bulleted items. So there's 2 for constitutional. There's quite a few for musculoskeletal. Even on the left-hand side here, there's some for cardio, lymph, skin, neuro, and psych. But you can see for a detailed exam, it could be 12 or more of any of these bulleted items. Any of them at all. But for comprehensive, you need them all. So really for the 1997 musculoskeletal exam, you really need help with some sort of a template to make sure that you would capture all of this information. So just make sure the exam, of course, is real time. So you can't indicate no change in the exam from the previous encounter. Let's go on to the third key component, and that is medical decision making. And of course, this is the most subjective part of the E&M guidelines, where the auditor is looking at your assessment and plan, and from that, they're trying to determine the complexity of the service. So there's some documentation tips that I want to give you that will help you support the complexity of the service. So I'm going to go over what we call 3 medical decision-making tables, just so that you have an idea of how the records are looked at. And again, I'll point out some key pieces of information that are important to document. So there's this one table that's called the number of possible diagnosis and management options. There's a second one looking at the complexity of maybe diagnostic tests that you ordered or reviewed. And then the third is what they call a table of risk that just has examples. There's 4 types of medical decision making. So it could be anywhere from straightforward to low complexity to moderate and to high. And so based on these 3 medical decision-making tables, that's how the auditors try to come up with the correct complexity of the service you're provided. So for example, the first table that's looked at, it's based on points. And these are not the number of problems, these are the points given to the problem based on how you've documented the problem. Is it stable? Is it not stable? Then there's the amount and complexity of data. That's the second medical decision-making table. Again, there's a point system involved. And then the third, which is the table of risk, this is just a list of examples, and I will show you what that looks like to try to kind of put it all together. So it's really important that you document the complexity of the service and the status of the problems. So for example, if we were auditing a record and it was a follow-up visit, we would look at these 2 line items here. Established problem, stable or improved, versus is it an established problem that's not stable? It's not controlled, it's worsening, it's failing to progress, it's an acute exacerbation. Those are some of the key words you could put in there to let the auditor know, no, this is not a stable problem. So it's based on point system. One stable problem is going to lead to a 99212. 1 point is typically a very straightforward medical decision making. Whereas if you somehow indicated, no, this problem really is not stable, I'm not pleased with the progress, however you want to word that, it'll at least give it 2 points. 2 points typically leads to low complexity, which is a 99213. So it will make a difference in the levels. Now, if you are evaluating multiple problems, this is cumulative. So if you had 3 stable problems, it wouldn't be 1 point, it would be 3 points. And of course, that leads to moderate complexity and at least a 99214 typically. Now, if you have a new problem, and it could be a new patient, or it could be an established patient with a new problem, we would be looking at these 2 line items. Okay, are you doing additional workup to decide what the diagnosis is or not? If you're not doing an additional workup, that means you're able to determine what the problem is. That's worth 3 points, but that's a step toward moderate complexity. 3 points usually leads to moderate complexity. A new problem with additional workup, 4 points, that's 1 step toward high complexity. But again, the other medical decision-making tables have to be looked at. So the important information here is document the status of the problems, particularly for those follow-up visits. You know, is it stable or is it not? And particularly if it's not, document that. It could be just 1 or 2 words. If you have a problem without an established diagnosis, you're not able to determine what the diagnosis is at this point, definitely document your differential diagnoses. You know, usually documented as probable, possible, rule out, because that certainly adds to complexity, usually leads to at least moderate complexity. You're probably going to have to do some additional testing. What you don't want to do with your ICD-10 code is don't pick an ICD-10 code based on probable, possible, or rule out. In this case, just code the symptom. And then, of course, document your treatment plan. So what is additional workup with a new problem? Any additional tests or diagnostic studies that you have to order. It could be a request for a consult. Maybe you need a colleague with some expertise. Or maybe you need to review records of the requesting or treating physician. Maybe the physician needs to send you additional records. They're not in your EMR, and you need to do additional work to get those records in and review them. That's additional work. Also, new versus established problem. Problems are defined relative to the examiner or the physician, not the patient. So if this problem is new to you, even if it's not new to someone else in your practice, if it's the first time you're seeing the problem for the first time, you can consider that a new problem to you. So ideally, the assessment and plan would look something like this. You would document the condition and the treatment and link them so that it's clear this is the problem and this is what I'm doing about it. And again, responding to therapy, we would consider this stable and give it 1 point. But sciatica right side, symptoms worsening, definitely 2 points, or a total of 3. So here we have moderate complexity right here. And a data point for MRI ordered. Now, note, diagnoses listed in the assessment and plan, but not otherwise supported with a status or treatment plan, are not going to be considered toward assigning that level of service. They're not going to be added into the complexity. And you don't want to choose ICD-10 codes from the problem list if they were not addressed in the visit. So, and there are some notes. I did kind of snip one of the notes out here where we see in the assessment, and there's a lot of conditions listed here, but we weren't able to link, you know, a plan or whether or not there was a status with some of these. Like, wasn't quite sure, were all of these conditions really addressed or which were? So definitely we need to know and have linked the treatment plan with the condition and a status. So again, qualify your diagnosis. And again, is an acute exacerbation is very good verbiage, or is the severity of it the chronicity. And don't forget your comorbidities, anything that may affect your medical decision-making, decisions for treatment, decisions for medications. For example, here's a note where the provider added in the fact that the patient had MS and was taking that into consideration in determining what sort of treatment needed to be undertaken. Let's look at medical decision-making table number 2, and this is the amount or complexity of data to be reviewed. So it could be lab tests, imaging, discussing results with another MD. Maybe you're discussing something with the radiologist. Decision to obtain and review old records. Reviewing and summarizing those old records, but you'd actually need like a summarization documented. But this is something that you may be doing, going into the PACS system and independently reviewing an image. What you need to do is just document that you did that, independent interp, and then a brief interpretation. So let's take a look at what that table looks like. So again, this is table number 2. The auditor is kind of looking through your note and trying to determine, did you order any labs, imaging studies, any other diagnostic tests? 1 point for each of those, and you notice it's a maximum of 1. No matter how many labs, for example, you're only going to get 1 point for all labs, or 1 point for all imaging studies. But again, the additional points, and they add up. If you're discussing results with another MD, but you'd have to document that. Any of these items that you're doing, you would just need to document that. And here's some verbiage, recommended language that you could use for some of that. Let's talk about medical decision-making table number 3, and this is the overall risk of complication. We call it the table of risk. And again, we'll look at the examples that are in there, but it could be based on presenting problems or maybe diagnostic procedures you ordered or possible management options. And we really do try to look at, okay, what is the highest level of risk that we can identify and kind of map to your assessment and plan. And of course, the examples are not all inclusive. That's the problem. So it does get a little bit subjective in this area. Don't forget your comorbidities that are documented that can help support complexity. And any kind of procedures that you needed to order are important. So this goes on through 2 slides. So minimal, of course, probably this is not going to be in your practice, but low complexity could be. It could be an acute, uncomplicated injury, ends up just being something very uncomplicated. Or think about those minor surgeries that you're doing and the patient does not have any risk factors, okay? They don't have any of the comorbidities. So typically your minor office procedures, your OMTs, your trigger points are gonna fall into low complexity. So typically the E&M with them would end up being a 99213 based on that, unless there were other conditions that you were addressing, of course, then that would be added in. But if you take a look at moderate complexity, those same minor surgical procedures that you're doing in the office, but you've documented that the patient has comorbid, they're bringing some kind of risks into the procedure that affect your decision, like, yes, I know they have AFib, they're on Coumadin, but I've decided to go ahead with this procedure, would help quantify it into a moderate complexity. Or just some other examples, 1 or more chronic illness with mild exacerbation, your undiagnosed new problem falls into moderate, prescription drug management falls into moderate. It gets into high complexity based on the severity and how you've documented that. But let's just go through an example where the auditor is going to look at these 3 tables to try to come up with what is the correct level of complexity for medical decision making. So maybe you've documented the patient has low left shoulder pain and it's stable, but now they have a new symptom of low back pain. So on the first medical decision making table and the point system, we have 1 stable problem for 1 point. But now we also have a new problem, additional workup was planned, So that's a total of 4 points for that problem, and overall total of 5. Well, once you get to 4, that's one step toward high complexity, but again, we've got to look at the other medical decision-making tables to determine overall. So maybe on the second medical decision-making table, you've ordered an MRI, so this, actually radiology would be circled for 1 point, but then you went into the PACS system and you looked at a previous image and you documented it and interpreted it for a total of 2. So this is a total of 3. 3 points leads to moderate complexity. So now we have one table that meets high, one table that meets moderate. And so overall, now we've got to try to determine on this overall table of risk where this problem falls in. Well, typically a new problem plus an established problem, it's going to fall into at least moderate. And then depending on the severity that you documented. But on this one, well, reasonably and based on the nature of the presenting problems, moderate complexity. So we saw here that, okay, we had one table that met high complexity, but the other 2 fell into moderate. So this reasonably would fall into a 99214 as an example. Let's take a look at a couple of other examples. 99213 example, a typical 99213. Now remember, the history and the exam only need to meet expanded problem focused, and you only need to count either the history or the exam. And this definitely qualifies for at least an expanded problem focused history. We have 4 HPI elements and 1 review of systems. We have a detailed exam. But we want to look at the medical decision making and make sure that it falls into at least low complexity. Well, documenting worsening is important because that at least gives it the 2 points that you need for low complexity. So the cognitive labor required for the clinical example satisfies the requirement for low complexity. There's 2 problem points on the first table that leads to low. There wasn't any data. Well, remember, we only need to count 2 of the medical decision-making tables. So the first one led to low complexity. The table of risk, which is the second one we're counting, is actually moderate. One problem with mild exacerbation is moderate, but of course, now these tables are kind of conflicting with each other, but remember, at least 2 of them have to meet the criteria. If they don't, you're going to default to the lower one. But really, one problem that's not stable is typically going to be your 99213. Now, this could be a 99214 if in fact you added in the fact that the patient has a comorbidity, rheumatoid arthritis contributing, and based on looking at that, you are thinking about med management or treatment management. Make sure you document that, and you could then qualify for the 3 points on that table to get it to moderate, and we know that the table of risk fell into moderate. Another 99214, 2 problems. If one problem is stable and one is not, again, that does qualify for a 99214, but again, make sure you document your status. Because typically 2 stable problems are going to be a 99213. If one of them is not stable, or both, that will get you to your 99214. But then again, remember, you want to make sure either your history or your exam is at least detailed. And then your typical 99212 is 1 stable problem. Let's talk about that time that's associated with the E&M codes. Because as I had stated, there are typical times attached to those codes. You don't usually need to worry about it. However, if more than half of your session ends up being counseling, more than 50% of the encounter, you feel you have done counseling with the patient, now you can actually look at the typical time associated with that code and use that to select your level of service and not worry about those 3 key components. But what do you need to document? You've got to state total face-to-face time, whatever it is. In this example, total face-to-face time is 40 minutes. More than 50% spent counseling on treatment options. Document them relating to the diagnosis of. Well, 40 minutes is the typical time associated with 99215. You would not need to worry how much you documented for your history exam and medical decision making if, in fact, more than half the visit was spent counseling. And just make sure that you document in sufficient detail, a sentence or two, what the counseling was about. A 99214 typical time is 25 minutes. So you would, in that case, you would state face-to-face time was 25 minutes, more than half spent counseling. A little bit about consults. For those contractors that still accept consult codes, I know they're getting fewer and fewer. We know Medicare doesn't, and a lot of the other ones, it's hard to say which ones do and don't anymore. But if you are billing a consult and it's accepted by insurance, make sure you document the request and the reason for the consult, and use consult language. I was asked to see this patient. I'm consulting for Dr. So-and-so, and what the reason is. You render the service, and then make sure you can track a response back to that requesting physician. Any tracking method is sufficient. If it's within your EMR, that's fine. If it's a fax, that's fine. If it's some sort of an e-tracking, that is acceptable. But again, as an example, document in the beginning of the note that it's a consultation. This patient's seen in consultation at the request of Dr. Wilson for evaluation of low back pain. That will help confirm that it's a consultation. And then make sure you can track that response back. And then this is just an example of the consult codes. The criteria is the same as new patient visits. The only difference is the times attached to them. Let's talk about the OMT procedures. Of course, you're familiar with these OMT procedures. These are the typical codes that you use. Just keeping in mind, it's based on body regions, anywhere from 1 to 2 to 3 to 4, etc. And of course, these are the examples of the body regions that they're referring to. Keeping in mind, lower extremities is one body region. Upper extremities is one body region. So as an example, if this patient came in and you were doing treatments on the right shoulder and the right SI joint, and then the left shoulder and the left SI joint, this is no more than 2 body regions. So again, make sure that these codes are based on the number of body regions that were treated, and clearly note which ones are being treated. And why I say that is that in some of the procedure notes that I saw, instead of stating the body region that was being treated, it was listed as an ICD-10 code. You know, I am treating M06 or whatever those codes are, M99.03, instead of I am treating L1 and L2. So remember, a written diagnostic statement, not just the ICD-10 code. This is within the procedure note itself. Only one should be billed per day. And this is important. Factors that may affect the frequency and duration of treatment. Make sure, you know, some of the patients that are coming in for multiple treatments, make sure that you document as you're doing continuation of treatments why they still need the treatments, the severity of illness, the duration or chronicity of the patient's condition. The medical necessity is going to be really important, because sometimes with these multiple treatments, if the patient's not responding and you're still doing the treatments, you've got to state why you are still doing those treatments. Because after a while, the insurance contractors are going to start asking for the records when they see the multiple treatments, and they're going to want to see why you're continuing to do multiple treatments after a while. So let's just look at an example of an OMT note. And of course, you would document in the beginning of the note the patient being seen and why, the fact that, okay, we've got somatic dysfunction of the lumbar, pelvis, and sacral regions. And then just a description of the pre-service work, the decision to perform, the verbal consent. Again, the intra-service work, this is the procedure note where you definitely want to document the regions that were treated, and not in ICD-10 codes, but in the description of the regions. And then, of course, the techniques that were used. And then post-service for post-care instructions, patient's response, etc. So because OMT is considered a procedure, document a separate procedure note. And particularly when you're doing an E&M with a procedure, document your E&M separately and then document your procedure note separately. And of course, all regions of somatic dysfunction should be documented using the TART terminology. So let's talk about national government services and their LCD. And this has to do with, okay, I should be able to bill the E&M service, I'm sure. But what does National Government Service say about it? Well, they say OMT specifically encompasses only the procedure itself. And the E&M services are covered as a separate and distinct service when medically necessary and appropriately documented. So that's the key, is that you just want to make sure, you know, as we just talked about, the E&M is separately documented and that it is a significant, separately identifiable evaluation and management service over and above that procedure. And then you put the modifier 25 on the E&M service. Now, they go on to qualify this and they state this: OMT utilized at a follow-up visit is not the same as follow-up OMT. Okay, so if they see in any insurance contractor, because we know there's problems out there with the insurance contractors trying to pay for an E&M and a procedure. This is true of all specialties. There's just sort of an initiative out there where they are kind of taking a look at E&M and procedures and not wanting to pay them both. So if that's the case and any additional documentation needs to be sent in, you definitely want to make sure that your documentation does support the fact and justify the fact that the E&M service should be justified. And it's still no guarantee that they'll pay it, but it gives some groundwork. Now, this follow-up EMT means to at least the Medicare contractor that it's predetermined, and therefore the E&M is not supported. And that may be true. You know, if you have a patient where you know they're coming in for a series of OMT treatments and you've evaluated them initially, when they come back for those treatments, just bill the OMT procedure code. Whereas if it's a follow-up visit where it's not predetermined, you weren't sure from visit to visit whether or not they need another treatment, and you need to reevaluate them each time, that's a follow-up visit where OMT may be utilized, but not necessarily predetermined. But the documentation has to support that differentiation. And then you would put a modifier 25 on your E&M service. So again, don't bill an E&M if in fact you know the patient's coming back for the procedure and that's what you're doing. Even if you do, some E&M documentation. Now, when can you bill the E&M? If there's a new condition or the patient's condition has changed substantially, necessitating an overall reassessment of the treatment plan. So you need to document this. Make sure that that's well defined in your note, that this is necessary to do. Or don't bill an E&M if you've done your E&M service today, but for whatever reason the patient cannot stay to have that treatment done today and they've got to come back the next day, for example. The next day when they come back, just bill the OMT. So let's look at an example where both of the E&M and the procedure should be billable. So, and it could be a new patient or an established. Typically, new patient visits, you should not have a problem getting the E&M paid because typically you need to do the whole evaluation to determine the course of treatment. An established patient coming back with new complaints of low back pain, just make sure that that's stated. You know, it's not a continuation, but it's something new. Make sure that you have a well-defined history, an exam, any diagnostic work that you've either reviewed or ordered. So all the work of that E&M is within here. And then you have your assessment and plan in indicating that the patient would benefit from OMT, and of course a verbal consent is obtained. So this should be billable with an E&M, modifier 25, and your OMT procedure. And you link the diagnosis codes. Now the ICD-10 codes, they should be allowable as the same code. And that depends, it depends on why you're seeing the patient for the E&M. There may be other conditions or other symptoms that you could link to that E&M service. You do definitely want to link the somatic dysfunction to your OMT. When does it come questionable whether or not the E&M can be billed? If you're not clear about the intent of the visit. Same established patients come into the office with continued complaints of low back pain. Well, that gives the impression that they're just coming back for another treatment. So again, just clarifying the intent. In this case, if it's not clear, the E&M will not be supported. So definitely just the procedure code would be allowable. Another example, that same established patients coming to the office, they had previous OMT treatments, but now you're stating you've got to reevaluate this patient because they're coming back with maybe new symptoms of low back pain. It's come back. It was previously relieved. Now it's coming back. Or there may be other symptoms that they're having that leads you to decide, it really is the procedure that needs to be done. Reevaluation is required to determine appropriate treatment. That's an important statement or something to that extent to make it clear. And again, that you've got components of history and exam, any diagnostics that you're looking at or ordering, and then your assessment and plan, and even state based on evaluation, this patient would benefit from another OMT treatment or another series. So again, describing how and when the patient's condition has substantially changed, the reassessment of the treatment plan was performed, or this patient's visit was not scheduled for the explicit purpose of OMT on that date. Let's take a look at trigger point injections. There were a couple of trigger point injections that were not well documented or well supported. So there's two codes for trigger point. 20552 involves one or two muscles, and 20553 involves three or more. Now, the Medicare contractors are saying the involved muscle groups must be documented in the patient's medical record as well as the number of trigger points injected. And a diagram with an X or other similar annotation is not adequate documentation. So again, make sure you document the muscles involved and the anatomic site and the drug and dosage. Also keep in mind, if you're doing the procedure under any kind of image guidance, you can also bill additional image guidance with these codes. This one is ultrasound guidance. I believe this is fluoroscopy, and I think this one is magnetic resonance. So again, this is just an example where, again, the muscle involved is being documented. Indicate medication in milligrams is another key point. But a lot of trigger point injections that I've seen, not necessarily in your practices, just overall, I see a lot of notes like this. I did inject the trigger point with whatever meds. That's not going to support the procedure. So just make sure the muscles involved, prep of the site, etc., and the med. Don't forget your meds because you can bill separately for specific medications. And document them in milligrams because most of the J codes are defined in milligrams. A little bit about acupuncture. The acupuncture codes, keep in mind that there is a code for the initial, which includes the initial 15 minutes of personal one-on-one contact with the patient. And then there's an add-on code for each additional 15 minutes. There's an initial code for without electrical stimulation. So if you're not doing e-stim, use 97810 as your initial code for the first 15 minutes. And then you can use the add-on code 97811 for each additional 15 minutes. Make sure you document your time. And this is the personal one-on-one contact with the patient time. It may not necessarily be continuous, but make sure that you document it that way. And then if you are using e-stim, the initial code would be 97813 for the first 15 minutes, one initial code, and then for each additional 15 minutes, the 97814. And yes, you can bill an E&M with the acupuncture procedures, but again, the same guidelines that we had just talked about. A little bit about ICD-10 coding that I noted in some of the notes. Make sure that you only assign the ICD-10 codes that are supported by the documentation within the visit note. On some of the notes, I saw an awful lot of ICD-10 codes that were listed, appeared to be listed on the claim, but they looked like it just came off the problem list. So you don't want to assign ICD-10 codes from the problem list unless they were addressed within the note. Avoid unspecified codes if there's another code more specific, as long as it's supported in the documentation. Don't forget laterality. Okay, what I mean by that is, right shoulder versus left. There's codes for that. Pain in the right shoulder versus pain in the left shoulder. There's also a code for pain in unspecified shoulder. You don't want to use that. The insurance contractors are definitely taking issue with laterality. So make sure you document laterality and then choose the correct ICD-10 code. Documenting all conditions that coexist at the time of the visit and require or affect patient care treatment. So those are your comorbidities. If they're affecting your medical decision-making and therefore the complexity of the service, you want to make sure that you assign an ICD-10 code. Don't select codes from the problem list if not addressed in the visit. I think I already said that. And then here are the typical ICD-10 codes that support, your OMTs. A little bit about cloning. National Government Services, actually all the insurance contractors have very specific policies on it. What they're talking about is that when the same patient, the notes from visit to visit are worded exactly like previous entries, they definitely take issue with that. Certainly there's going to be some information that's going to be very similar or the same. That's not the problem. But when several notes are worded exactly and they don't see anything changed at all, they could deny the claims. So any specific information, if you're carrying forward, copying, pasting, those are all tools in your EMR that, you should be able to utilize so that you don't have to redocument a lot of information. Just make sure that you update anything that's changed, anything pertinent, no matter how small it is, because that's the kind of information that will be tracked. And then, of course, based on that, CMS realizes that they are trying to relax the standards a little bit, knowing, and they've heard from the providers, believe me, that the E&M guidelines are way too complex. So what they stated, this is new for January 2019, it's really a small change, but what they state, for history for established patients, when relevant information is already contained in the record, practitioners may choose to focus their documentation on what has changed since the last visit, or on pertinent items that haven't changed, and need not record the defined list of required elements if there's evidence the practitioner reviewed the previous information and updated it as needed. Well, I know in my experience, most providers seem to copy forward or copy paste, so it's kind of along the same lines of updating anything that you bring forward and make sure it's updated. But so for the history for established patients, when the relevant information is already contained in the record, you can simply focus your attention on what has changed. is basically what they're saying. So someone did ask, what parts of the history can be documented by ancillary staff or the patient, beneficiary meaning the patient? What CMS said about this? Any part of the chief complaint or history that is recorded in the record by ancillary staff or the beneficiary, meaning the patient, does not need to be redocumented by the billing practitioner. So this is good information. What they're saying is instead, the information that's already documented, the practitioner, the physician, can review the information, update or supplement it as necessary, and indicate in the medical record that you have done so. So just make sure that you indicate in the record that you've reviewed what ancillary staff may have documented. And that's everything. Thank you.
Thank you very much, Susan. Great information. Any questions that you may have can be directed to physicianservices@osteopathic.org. We will be happy to respond to them. And if it's something that needs Susan's assistance, we will refer that to Susan. Thank you all for joining us.